So good afternoon. I think some of the material that I'm going to present has been discussed in different shapes or forms at different times of this conference, but I think this is a good opportunity to summarize some of our thinking about how to predict outcomes in patients with traumatic brain injury. So this is really the dilemma. These are two CAT scans. These are two of my patients. On the left, you have a young man, 29 years old. He was intoxicated, fell down the stairs. He arrived in the ICU with a Glasgow coma scale of 4. He had a subdural hematoma, went to the operating room, was operated, removed, and came back to us with what you can see here, which is a right frontal contusion, a right temporoparietal contusion. And this patient, who initially looked very poor on clinical exam and by CT scan, within 5 days was awake and following commands. Within 1 week of admission, he was extubated. And within 2 months after discharge, he was back to his job. He works as a cook. Now, on the right, you have a CAT scan, which is of another patient, which I think you would agree looks quite similar. This is a 34-year-old man, father of 3 children, involved in an automobile accident. He also sustained severe traumatic brain injury. He was initially in another hospital and then transferred to Johns Hopkins. He had an intracranial pressure monitor. His evolution went from a Glasgow scale of 4 to a Glasgow coma scale of 5, and then ultimately, after 2 weeks of very aggressive resuscitation in the ICU, he progressed to transtentorial herniation and developed brain death. So how do we explain these very different outcomes in 2 patients who clinically, when they first came to us, looked quite similar? So here are some basic points that I would like to emphasize. The first is that something which we all know, which we all repeat, but it's important to remember, and this is that traumatic brain injury is heterogeneous. It is a heterogeneous disorder because of underlying biological heterogeneity in the injury of the brain. We know that the outcomes after TBI really is the result of a convergence of multiple factors, and we're going to discuss some of those factors this afternoon. I think we can say in fairness that the clinical examination, with all due respect to Tarek and others, and also the cranial CT scan provide valuable information, but they are not sufficient to make accurate predictions about even short-term outcome in severe traumatic brain injury. I think there's a great deal of promise with the measurement of biomarkers, and we discussed this a little bit this morning. They can be biomarkers, in the blood, in the CSF. They can also be biomarkers directly measured in the brain using techniques such as microdialysis. And I think you have seen that I have an inherent bias, and I believe that imaging techniques, in particular MRI, can provide us with extremely valuable information to understand TBI outcomes. So this is a scheme that, or a sort of model that I would like to propose with regards to traumatic brain injury. We know that when you have traumatic injury to the brain, this will result in cellular dysfunction, cell death, with a sort of cascade of possible consequences. One of them is that there's going to be significant scarring and gliosis in the brain. This is a very common pattern. But interestingly, there's also going to be a lot of, and independently, there's going to be a lot of neurodegeneration, and we mentioned this earlier today as well, this atrophy that seems to occur in the brain after severe TBI and which is widespread, regionally selective. But also, and this is perhaps something that we understand the least well, there is going to be a significant amount of plasticity, of reorganization of the brain, of remodeling, and this is a process which is fundamental and which I think probably contributes just as much to TBI outcomes as do the other factors such as degeneration and tissue scarring. So the result of all this, the outcomes that we observe, the phenotypes that we see in the long term, I think really depend on these converging issues. So what are the outcomes that we can measure after TBI? We can break this down into short-term outcomes. Things like survival in the hospital, in the ICU, duration of coma, duration of post-traumatic amnesia. These are very standard short-term outcome measures. And of course, for studies that are based in the ICU, we often see things like length of stay, duration of mechanical ventilation, incidence of organ failure, and so forth. But perhaps what's more interesting or fundamental in terms of understanding outcomes after TBI is to characterize the long-term outcomes. And these can be characterized in many different ways. We can think in terms of neurologic function. You know, does your patient have hemiparesis 1 year afterwards, after the insult? In terms of cognitive function, you know, is there a memory problem? Is there an attention problem? Is there an executive control problem? We can think in terms of psychological well-being, and this is something which is not so well studied, but which is beginning to be understood. Many survivors of traumatic brain injury have long-lasting depression, they have anxiety disorders, they can have post-traumatic stress disorder. We can think in terms of functional status and in terms of disability. What is how has your patient reintegrated into their life? Are they able to return to their prior level of work or school or whatever it was they were doing before they had their accident or their insult? And perhaps most importantly, we can think in terms of quality of life. How does the patient himself or herself subjectively assess their life? How do they feel about the quality of their life? And is it the same as it was before? In most cases, this is not the case, unfortunately. Of course, there are a number of different scales. Dr. Vincent was mentioning some of these earlier, but there's a number of different scales that can be used to assess, to measure function after TBI. The most common one is the Glasgow Outcome Scale or the Extended Glasgow Outcome Scale. There's also the Disability Rating Scale, the Rankin, Barthel, etc. I'm showing you this slide because these scales are interesting and they provide a quantitative estimate of what's going on in a patient. However, they are very coarse. They are not able to detect much more subtle problems that are prevalent in the TBI population. And I'm thinking in particular of neuropsychological issues with attention. The fact that a patient, for example, cannot remember where he or she put her keys, the fact that a patient is experiencing anxiety every time he or she goes to the supermarket. These are things that maybe are not captured by these functional outcome scales, and yet which can severely impair someone's quality of life. So when we think about predicting or attempting to predict outcomes after TBI, there's really two sort of classes of methodology. One is the very simple establishment of an association between a factor that we observe acutely, such as, for example, the number of hours that a patient's ICP was above a certain level, and outcome. And so these are these univariate associations. Many studies have been conducted. In fact, the vast majority of studies in neurotrauma are looking at univariate associations. But perhaps what's more interesting in terms of being able to accurately interpret outcomes is the use of multivariate models where we can put together a number of different parameters and then independently adjust for the others to determine the strength of the association between a variable and a specific outcome. So this is the basic concept in terms of developing a prognostic model. We have to think in terms of factors that are related to the underlying neurological and physiological reserve. We have to think about how severe is the insult, and we have to think as well about recovery and repair mechanisms, although at this stage they are difficult to measure and to ascertain. What do we mean by reserve? Reserve really is a concept that is emerging increasingly in critical care and has to do with the intrinsic ability of an individual to respond to an insult, to an injury. And this is very variable. It's heterogeneous. It's probably in part determined genetically. We don't really know. But we can talk about neurological or brain reserve. And what plays into neurological reserve are things like age, prior neurological function, level of education, and certainly genetic factors. And then there's physiological reserve, which has to do also with age, which has to do with the frailty of the individual, this individual's nutritional status, the presence of comorbid conditions. All of these things, these different aspects of reserve are going to play a significant part in determining outcome after TBI. And what about measuring the severity of the insult? So this is where the vast majority of TBI research has focused on, is efforts to determine how severe, how bad is the injury. And this can be done in a number of ways. It can be done by assessing the neurological exam, by looking at systemic physiology, by looking at neurophysiology, and that's what the topic of this conference here in Rome, measuring ICP, brain tissue oxygen, lactate to pyruvate ratio in the brain interstitial fluid, etc. We can do this using electrophysiological methods, EEG, cortical spreading depression. We can do it using imaging, of course. So in terms of clinical exam, it is true that basic factors such as the level of consciousness or the presence or the absence, I should say, of pupillary responses are fundamental and highly predictive. So this is a graph from the CRASH data set demonstrating a virtually linear relationship between the outcome of death at 14 days and the Glasgow coma scale. So the lower your Glasgow coma scale on admission after TBI, the higher the likelihood that you will die in the first 2 weeks after injury. This is a slide that was shown on the first day of this conference by Professor Vincent, relating the systemic insults, hypoxia, hypotension, and the likelihood of death after TBI, a fundamental concept which I think all of us have assimilated. What about CT scan? This is one of the most frequently cited studies in traumatic brain injury. It's the Marshall score, the Marshall CT classification, which is a very simple score. It takes into consideration whether or not there's a mass lesion, whether that lesion has been evacuated, takes into consideration whether the basal cisterns are compressed by cerebral edema, takes into consideration whether or not there is shift of midline structures. And using this very simple scheme, you can actually find an association with mortality. Okay, so the higher Marshall scores tend to be associated with a greater likelihood of death. More recently, a group in the Netherlands has elaborated on the Marshall score by incorporating intraventricular hemorrhage on CT scan and also subarachnoid hemorrhage on CT scan. These are two additional elements who have been found to have independent prognostic value. And so they have made their modification of the Marshall score, which is now called the Rotterdam score, and which is quite a predictive element. So if you have a patient with this, for example, you can see, I don't know where my, here. You can see the point of impact here, a little bump on the skull, and you can see this extensive hemorrhagic lesion, which is in part subarachnoid, in part intraparenchymal, this left frontal lesion, and probably there is a small subdural associated. And here you can see that there's also some bleeding occurring in the corpus callosum. So this patient has traumatic subarachnoid hemorrhage in it. This is a patient with a right temporal contusion, and you can see here that there is some blood collecting in the occipital horns of the lateral ventricles. And so this patient has traumatic intraventricular hemorrhage. These are factors that have been associated with worse outcomes after TBI. Let's talk a little bit about these multivariate scoring systems that have been developed recently. So the best known ones are the IMPACT. This is the International Mission for Prognosis and Analysis of Clinical Trials. And then there's the CRASH. So the IMPACT is essentially about 10 randomized controlled trials conducted in the 1990s. The data from these trials was assembled into one large database, close to 10,000 patients. And the CRASH was, as you know, a randomized controlled trial looking at the effect of high-dose methylprednisolone in patients with severe or traumatic brain injury. So these are the outcomes of the IMPACT and the CRASH. You can see here the IMPACT database, 9,200 patients, and you can see that the distribution of outcomes at 6 months, 50% either vegetative, severe disability, or dead. And here in the CRASH database, very similar in terms of outcomes. 10,000 patients, close to 50% experienced a very poor outcome at 6 months. So these are some details on these different scoring systems. This is the IMPACT score. You can see that the outcome is 6 months mortality or unfavorable outcome. The core model includes age, motor portion of the Glasgow coma scale, and pupillary reactivity. There is the core plus CT, which includes elements of the Marshall score. And then there is the core model plus CT plus lab, which includes glucose values and hemoglobin. Then there's the CRASH model, and the outcomes are either mortality at 14 days or unfavorable outcome at 6 months. This includes very similar age, Glasgow Coma Score, pupil reactivity, major extracranial injuries, and then the core model plus, which looks at additional factors, in particular on the CT scan. So using these two models, you can see that these models have been validated both internally within their own data set, and these are the areas under the receiver operating characteristic curves. You can see that it's anywhere between 0.77 and 0.84 for the crash, and for the impact, you can see as well that it has been internally validated. But what's important perhaps as well is to note this line here, this external validation. So the crash model has been externally validated against the impact, and the impact model has been externally validated against the crash. So this is a very, very important criterion in terms of determining the validity or the usefulness of a scoring system. Can you validate this scoring system in a completely separate population? And this is the case for both crash and impact. So we talked about internal and external validation. We need to also talk about a few other characteristics of predictive models. One of them is discrimination, and this is essentially what we obtain when we use the receiver operating characteristic curves. How good is your model at separating those individuals who will have a good outcome and those who will have a bad outcome? And then there's the question of calibration, which has to do with how close is your patient population in outcomes to what would be predicted by the model that you use. So here you have, again, the external validation, crash versus impact, impact versus crash. Very nice concordance between these two studies. Let's talk a little bit more about some of the additional methodologies for predicting outcomes in TBI. What about electrophysiology? I think we can resume a lot of available data by saying that EEG is not a very accurate or helpful predictor of outcome after traumatic brain injury. On the other hand, the somatosensory evoked potentials seem to be quite valuable. This is a recent paper in which the somatosensory evoked potentials were graded according to whether they were bilaterally absent, whether they were absent on one side, abnormal on one side, and all the way until normal. And these authors found that the somatosensory evoked potential grading system here was indeed correlated with 1-year Glasgow outcome scale. This is a very interesting recent paper just published in Lancet Neurology with an editorial by one of our chairs here, looking at the role of cortical spreading depression. This cortical spreading depression, which Dr. Vespa discussed earlier this morning, is a very interesting phenomenon. And it seems that you can record this if you place electrodes on the surface of the brain. You can actually record these spreading depressions, which can be either cortical or isoelectric. And in this particular study, small study, they found that the presence of either cortical or isoelectric spreading depression was associated with a propensity for worse outcomes. So very interesting, intriguing data. However, perhaps not very practical in the sense that it requires a craniotomy and placement of a grid directly on the brain. There's other ways that we can predict outcomes using physiology. So here is simply brain tissue oxygen levels, which we know to be predictive. When they are low, there is a correlation between brain tissue hypoxia and worse extended Glasgow outcome scales and worse functional status exams. This is a very nice study from the Cambridge group looking at microdialysis. You can see here lactate to pyruvate ratios, and you can see that there is a correspondence. Those individuals who had lower L to P ratios had worse outcomes. And this is a paper that was cited by Dr. Otto yesterday, looking at interstitial brain levels using microdialysis, interstitial levels of this neurofilament H heavy chain. You can see that there is a correlation between the elevations in this protein and physiological abnormalities such as lactate to pyruvate ratio, blood pressure, CPP, brain tissue oxygen. Very, very nice paper from Martin Smith in London. And finally, and we discussed this morning, this is a paper looking at imaging. This is data from Louis Pubasset, and you can see that the measurement of white matter tract integrity using diffusion tensor imaging is significant in terms of showing lower levels of fractional anisotropy, greater amount of white matter damage in those individuals who have worse 1-year outcomes. This is a project that is ongoing. We have now submitted a large grant for funding at the NIH. The plan is to perform a multi-center observational study of patients who are comatose after TBI. We are going to get diffusion tensor imaging and functional MRI 7 to 21 days after injury and 6 months after injury. The same scan will be repeated at 6 months, and this will be coupled with neuropsychological testing, and then outcomes will be assessed at 12 months. So to summarize, I think there are strategies that we can use to reduce the uncertainty that I was talking about earlier today with respect to TBI outcomes. We need to increase our knowledge of biological mechanisms. We need to understand better the genetic sources of variants. We need to develop more accurate biomarkers of injury. We need to understand better the neuroplastic phenomena that occur after TBI. We need prospective cohorts to determine what is the natural history of TBI, which is still very poorly understood. We need comparative effectiveness research, and we need to develop accurate predictors of outcome. So I will stop there. Thank you very much.